Welcome to this series of interviews with the giants of cardiac surgery. My name's Joel Dunning and I'm here at the EACTS conference in Geneva with Professor Pieter Kappetein. You're a cardiac, you're a thoracic surgeon, you're a transplant surgeon, you're a TAVI surgeon, you're associate professor at the Erasmus University in Rotterdam, and but more than anything, you've been working very hard as principal investigator of Syndics and also Excel, and also, in addition to all that, you're Secretary General of EACTS, and we're here today in the fantastic EACTS conference, which is now the world's biggest cardiothoracic surgery conference. So very well done on that. I wanted to talk to you about the Syndics study. You've just presented to us for the very first time the 3-year results. So for CTSNet, I wonder if you could first of all tell us a little bit about the study and also the 1- and 2-year results before we move on.
Yeah, so the Syndics study is a study that was designed to compare PCI versus coronary bypass surgery in the more complex cases, so patients with 3-vessel disease and or left main disease. And with the drug-eluting stent, it was thought that now finally perhaps stenting could mimic the outcome of bypass surgery. So the cardiologists challenged surgeons, saying, well, you know, maybe you have also improved, but let's then test it. Let's do a randomized study, see whether drug-eluting stent can close the gap between coronary surgery and PCI. So that was the idea behind the Syndics study. And obviously you needed a lot of patients, so we recruited 1,800 patients, 900 in both arms. And at the same time there was a registry, because it was clear that sometimes the cardiologists pick the good cases and the surgeon get the more complex cases. So we said we want to characterize a patient that could not be randomized, just to show to the outside world that the results of this trial can only be applied to a certain patient population. And I think that was one of the other unique features of the Syndics study. And the third one was that the Syndics score was developed, a score that could characterize the lesions in the coronary arteries. So these 3 things, I think, make the Syndics study quite unique. The 1- and 2-year results, at least, well, the 1-year result was the primary endpoint. And it was a composite endpoint called MACE. Major adverse cardiovascular and cerebrovascular events, and that means myocardial infarction, stroke, mortality, and repeat revascularization. And the 1-year results showed actually that CABG is still the golden standard, that they did not match the results of coronary surgery PCI. So, of course, then we're also curious to see, well, what are now the 2 years results, and then ultimately the 3 years results, and then 2 years down the road the 5-year results. Well, the 2 years results also showed that, confirmed actually that coronary surgery is still the golden standard. What we saw that in the more complex cases, there was really also a mortality difference now. So it's not only that patients came back more often after a PCI, but it also showed that the mortality rate was much higher.
And you did some sub-analysis, didn't you, into low, moderate and high risk in year 1 and year 2?
Yes. So the low risk Syndics score means that these patients have less complex disease, and their PCI did similarly as coronary bypass surgery, so we did not see a difference in MACE rate in that group of patients. But as soon as it gets a little bit more complex, which means a Syndics score above 22, then surgery is superior to stenting.
And I suppose the final thing in the sub-analysis was that left main stem but low Syndics score, which has laid the basis for the Excel study.
Yes. So it was quite a surprise. At the time that we started the Syndics study, left main stenting was not very common. In Europe it was done in quite a number of centers, but in the US it was quite uncommon still, and only little experience existed. But we wanted to have this all-comer study, and during the study, actually during the first enrollment of patients, we saw that there were quite a number of patients that had left main disease. Then we did a new calculation for a sample size, and we came up with a sample size of 700. But we were only allowed to do this analysis on left main patients on the condition that the overall population would have met the primary endpoint. So actually it's still a population which is quite small, 700 patients with left main disease, but surprisingly we could show that in this population, with the ones with a low Syndics score, so that are the ones with an isolated left main disease or with left main disease plus 1 vessel disease, PCI did quite well. And so that was a surprise actually, but the group is small, so it is more hypothesis generating than you can really draw a firm conclusion.
Yes, and I'm sure we'll talk a little bit more about that. So let's move on to the 3 years results. For you, what are the most important findings at 3 years?
Well, one of the most important findings for the 3 year result that you compare to 2 years results is that in the intermediate group of Syndics patients, it's now also clear that coronary bypass surgery is better than PCI. At the 2 years results, there was no significant difference, and now it has become significant. If you look closely in the different components of MACE, you also see that, well, mortality may start playing a role there, and also the mortality is lower with coronary bypass surgery.
And so just to be clear on that moderate group, what's the main driver for that difference? Is it revascularization?
The main driver remains revascularization, but you see also that myocardial infarction is going to play a role there. There's also a difference in myocardial infarction, which is higher with PCI.
And that came out significant in the moderate group?
That came out significant, yes.
That's fantastic. And what about the left main stem low syntax score? Is there anything new on that?
At this moment, these data are not disclosed yet. We have to wait for 10 days at the TCT meeting, and then the data will also be disclosed.
Okay, that's fine. And is there anything new on the stroke rate? I know a lot of people were maybe a little disappointed with the 2.2% stroke rate, which is just 19 patients, isn't it? But
yep.
Is there anything new on that? Have there been more strokes in the grafts group?
No. So it was actually a little bit what we could predict. It was a lot of the cardiologists focused on the stroke rate, which is an issue. We should not, move that away. But it was a small difference. As you said, there were only concerning 19 patients, which of course we should try to lower. Every stroke is too much, and is one too much. But now what you see at the 3 years results is that there's no significant difference in stroke rate anymore, because after the 30 days you could say that patients follow the normal stroke rate in a patient population with atherosclerotic disease, and which is between 0.6 and 0.8% per year.
So these results are outstanding again for grafts, and you've again at your conference seen the joint ESC/EACTS guidelines being published, which sets the new template for how we manage revascularization. How do these 3 year results sort of fit in with those guidelines?
Well, you can of course understand that William Wijns, one of the chairman of the guidelines committee, was very anxious to see the 3 years results, whether he should already start rewriting them a week after they appeared. But he was very pleased that actually it fits perfectly also with the 3 years results. I think it became clear for the guidelines that coronary surgery is still the golden standard in many indications, and actually Syndics more or less confirmed that. They of course had the 2 years data from Syndics available when they wrote the guidelines, and it's only that in the group between Syndics score 22 and 32 that you may say it's a stronger indication that you shouldn't do PCI.
Yes, I think in the guidelines, that moderate group, it's still a stronger recommendation for grafts, isn't it? But I suppose these 3 year results actually improve the evidence for that recommendation. And I suppose that's what you'd say to a cardiologist that actually only refers high-risk syntax score people, that confirms it, which is excellent. So let's move on a little bit to the Excel study. It's this left main stem low syntax score people that you're going to study. I believe it's sort of 2,500 patients, and you've got $17 million to do this study. Do you want to tell us a little bit about how you're going to be running this study?
Yes. So now it was clear from the Syndics data that there is an indication that left main might be as good as surgery, or at least non-inferior to surgery. But as I said before, the group was too small to actually draw that conclusion. And so the Excel study is aiming at confirming whether it is justified to do PCI stenting in patients with left main disease and low syntax score. There's a rationale behind it. I can see as a surgeon even that might be true that PCI is non-inferior to surgery in that patient population. It is a patient group where, for example, if you have a left main shaft or a left main ostium lesion, that the cardiologist can fix that in 15-20 minutes time, while we do the same operation for an easy lesion, you could say, that is easy for the cardiologist. We do the same extensive operation for the simple lesions as for the more extensive disease. And of course, if it is an invasive procedure, you more or less pay your price if you have to compete with somebody who can do that in 15 minutes without opening a chest.
Yeah. So it's going to be the next most important study. It's going to be another real groundbreaking trial. A few things are going to be different, aren't they? Certainly the rating of stenoses is going to be quite different from the FAME study. Is that going to favour the surgeons or the cardiologists more?
It might work in both directions. So angiographically, if there's a stenosis between 50% and 70%, you should check it, whether it's really flow limiting with an FFR, or you should do an IVUS.
Would that be a requirement in the study?
That's a requirement in the study. And of course it may work in both directions in a positive way, because if we place too many grafts to the left system, it might also not be very useful. And actually every anastomosis that you make, of course, may have a failure and may result in a failure, and thereby could potentially damage the coronary artery. If it's not necessary to place a graft, please don't do it.
And I suppose us as a surgical community, just like the cardiologists up their game all the time, we need to be upping our game. And I know we've talked about the stroke rate. I know 3 of the strokes were pre-operative, weren't they?
Yes.
And also our sort of total arterial revascularization rate was maybe a little low at sort of 18%, and off-pump rates sort of weren't too high. Is there anything you want to see done better by us in this next study?
Yes, of course, we hope that the arterial revascularization will become higher in the EXCEL study. I think we will see a patient population which is slightly younger than in Syndics and which is slightly easier perhaps than in Syndics. So I hope that thereby the arterial revascularization rate goes up. It would be very bad if now the arterial revascularization rate appears to be lower than in Syndics. You know, that we have a 28% bilateral memory artery grafting in Syndics, and that's the percentage I think that we at least should try to reach, and hopefully even more.
And will you have any recommendations for double antiplatelet treatment? I know some people felt maybe that stroke rate was because
yes,
the PCIs are all on clopidogrel.
Yeah, no, absolutely. That has been a long discussion. Of course, there's a difference between PCI and coronary surgery. I always say it's not just one medical treatment which differs, but it's the whole treatment is different. We open a chest, they don't open a chest. We use cardioplegia, they don't use cardioplegia. We heparinize our patient, they don't do it in the same extent as we do that. And of course, there's also a difference in antiplatelet therapy. But that does not automatically say that you can say, well, it's good in PCI, so it's also good in surgery that you give dual antiplatelet therapy. I've never seen any evidence that you should give clopidogrel to these patients. It might even be dangerous. And actually, during this meeting, we got data presented that showed actually that clopidogrel might even increase sepsis and side wound infection. So it's not so clear for me. And of course, you will have increased bleedings with clopidogrel. So maybe we need to do antiplatelet therapy, but for me, it's not sure that it should be clopidogrel. It might be, for example, also the new drug ticagrelor.
Yeah. So, a few final little questions. How important is it for a cardiac surgeon to know the syntax score? And if they haven't got a syntax score on all their patients, is it for them to actually work it out themselves? And where can they find out more about that?
So the syntax score can be found on the website www.syntaxscore.com. There's a calculator that you can use. In the beginning, people will find that it's quite labor intensive to do the syntax score. But after you get used to it, after you've used it 10, 15 times, it becomes much more easier, and you can do it in a few minutes. And if you're really used to it a long time, sometimes if you look at the angiogram and you make a guess, it's pretty close to what you can calculate with the syntax score.
Well, it's been absolutely fascinating talking to you. Where are we going to hear the 4 and 5 year results? Are they going to be here?
I guess that next year they want to have that at a cardiology meeting again, and the 5 year results, I guess, might also be at the ESC meeting.
Yeah. Anyway. It's been really impressive, and it's a stunning study, and it'll stand the test of time for decades to come. So many congratulations of leading it and leading the next study. So for myself, Joel Dunning, and the CTSNet team, I'd just like to say thank you very much.
Thank you very much.